So we're discussing placenta previa. A woman with painless vaginal bleeding in third trimester of pregnancy will suspect placenta previa and will confirm our diagnosis by a transvaginal ultrasound. And if it's confirmed on transvaginal ultrasound, then we'll monitor the patient. And if fetal distress develop or if some other conditions start deteriorating, then we will do a cesarean section and deliver the baby. Sometimes in the exam, the presence of a fetus in a transverse lie is a clue that you can see in this diagram that due to a low-lying placenta, the baby position is transverse. So a woman with painless vaginal bleeding and a transverse lie of the baby can be a hint to make a diagnosis of placenta previa. So can anybody give me an example of any other condition that can cause painless bleeding during pregnancy? We discussed that condition in gynecology.
Is it cervical ectropion?
Yes, that's right. Excellent. Pregnancy and COCP, both of them can cause cervical ectropion, and cervical ectropion can also present with painless vaginal bleeding during pregnancy. So you can confirm the diagnosis by a transvaginal ultrasound. If the transvaginal ultrasound show a low-lying placenta, then it will be placenta previa. And if the ultrasound is showing that the placenta is high-lying, but the still patient is presented to you with painless vaginal bleeding, then it will be cervical ectropion. Another condition that can cause painless vaginal bleeding during third trimester of pregnancy or after 24 weeks of gestation is Vasa Previa. How you will differentiate Vasa Previa from placenta previa? Both of them will present with painless bleeding, but Vasa Previa are basically the blood vessels or some of the blood vessels that connect the umbilical cord to the placenta. They usually lie over or near the entrance to the internal os. And when the membranes around the baby rupture, these blood vessels can rupture too, which can lead to a painless bleeding. So placenta previa is an abnormality of the maternal part of the placenta, and Vasa previa is a complication of fetal part of the placenta. So the differentiation is also based on this point. Both of them will present with painless bleeding, but if CTG shows fetal distress, then it will be Vasa previa, because the blood vessels that are taking the blood to the fetus are compromised or they are ruptured, so there will be fetal distress on CTG. So this is a differentiating point between placenta previa and Vasa previa. So three conditions can present with painless bleeding, that is placenta previa, Vasa previa, and cervical ectropion. Now another cause of antepartum hemorrhage, that is a hemorrhage after 24 weeks of gestation, is placental abruption. What is placental abruption? Placental abruption will present to you with painful vaginal bleeding. In placenta previa, there was painless vaginal bleeding. While in placental abruption, if there is vaginal bleeding, it will be painful vaginal bleeding. What is placental abruption? Placental abruption is, as you can see in this diagram and in this one also, that premature separation of the placenta from the uterine wall. So premature separation of the placenta before the delivery is known as placental abruption, and placental abruption can lead to internal bleeding due to premature separation of the placenta. And what will happen if there is internal bleeding? The blood will start to accumulate in the uterus, and the person abdomen will become hard, and there will be abdominal tenderness. So a woman in third trimester of pregnancy present to you with abdominal pain, vaginal bleeding, and hypotension because of bleeding, then you will suspect placental abruption. So the presentation of placental abruption is vaginal bleeding, abdominal pain, uterine contraction, which will cause tenderness, and because the placenta is separated from the uterine wall and there is bleeding, so the blood supply to the fetus will be compromised, which will lead to fetal distress. And when blood supply to the fetus is compromised or decreased, it can also lead to fetal death, intrauterine fetal death. And intrauterine fetal death can also cause DIC, disseminated intravascular coagulation. What are the risk factors for premature separation of the placenta? The risk factors are trauma. Any trauma can lead to the premature separation of the placenta from the uterus, preeclampsia or hypertension or smoking. All of them can cause, or multiple pregnancies can lead to placental abruption. What is the management of placental abruption? Placental abruption management is very simple because there is a bleeding, and so the blood pressure will be low. And if the blood pressure is low, then we'll give fluid resuscitation and blood transfusion. And the definitive management is cesarean section and delivery. So placenta previa present to us with painless vaginal bleeding, and placental abruption present with abdominal pain and vaginal bleeding. Now, if the scenario in the Plab 1 exam mentioned that, or if we are suspecting the placental abruption, then the first investigation or initial investigation will be cardiotocography to see if there is fetal distress. So in a suspected placental abruption, the initial investigation will be CTG and not ultrasound. While if you're suspecting placenta previa, then the initial investigation will be transvaginal ultrasound. Because in placental abruption, the blood flow to the fetus is compromised. So we need to do CTG initially to see if there's a fetal distress. And if CTG confirms fetal distress, then we need to do an urgent C-section. Otherwise, if we do not perform urgent C-section, placental abruption can lead to intrauterine death of the fetus and disseminated intravascular coagulation. That's why if you're suspecting placental abruption, then the first investigation that you need to do is CTG. If CTG is normal, then we will perform transvaginal ultrasound to rule out placenta previa. So if a woman present to you with vaginal bleeding and in the third trimester, and they ask you about the initial investigation, then it will be CTG. And if not given in the option, then the next best is transvaginal ultrasound to rule placenta previa. Now, a third cause of antepartum hemorrhage. Before discussing the cause of placental hemorrhage, let's discuss what is a pathological CTG. A pathological CTG is we measure the heart rate of the fetus. So if there's bradycardia on CTG, and then I will say that it's a pathological CTG. So acute bradycardia or even a single prolonged deceleration. What is a single prolonged deceleration? A single prolonged deceleration means initially CTG is normal, but then there is suddenly bradycardia, that so acute bradycardia and a single prolonged deceleration for 3 minutes or more, they are considered pathological CTG and it need an urgent intervention. What intervention can be done if a female present to you with a pathological CTG, such as there is a single fetal bradycardia for 3 minutes, then the first step is to change the position of the mother. Switch her to a left lateral decubitus position. Because sometimes what happens that due to large uterus or the large uterus can compress the aorta and inferior vena cava, and the compression of the aorta and inferior vena cava can compromise the blood flow to the fetus, which can lead to this single episode of deceleration, which may persist. Will always be changing the position of the mother to left lateral position. And after changing the position, we will give IV fluids. And if still the bradycardia does not improve, then we will prepare the patient for C-section and perform the C-section to deliver the baby. Conservative management is change position of the mother plus start intravenous fluid. If they ask you about the initial or immediate management, and the definitive management is emergency C-section. Now we will come towards the cause of antepartum hemorrhage or hemorrhage vaginal bleeding in the third trimester of pregnancy. That is uterine rupture or a ruptured uterus. So we have discussed that placental abruption can present with abdominal pain and vaginal bleeding. Similarly, a ruptured uterus will also present as abdominal pain and vaginal bleeding. So how we are going to differentiate between a patient of ruptured uterus and in patient of placental abruption? Remember that in case of ruptured uterus, the most important risk factor for uterine rupture is a history of cesarean section, because cesarean section it weakens the uterus or it weakens the muscles of the uterus. So a woman with a history of cesarean section is prone to develop uterine rupture. So someone with a history of previous cesarean section present to you with abdominal pain and vaginal bleeding and hypotension and tachycardia, then you will suspect uterine rupture. And a similar woman without a history of cesarean section and a history of trauma or multiple pregnancy or preeclampsia or hypertension or smoking, all these are risk factors for placental abruption, then you will say it's placental abruption. So you can differentiate between these two. The presentation of both of them is similar and they can be differentiated on the basis of history. History of cesarean section with abdominal pain and vaginal bleeding, ruptured uterus. history of preeclampsia or hypertension, and similar clinical features than placental abruption, or even a history of trauma or multiple pregnancies can lead to premature separation of the placenta. So then you will say it's placental abruption. So placenta previa cause painless vaginal bleeding. Placental abruption and uterine rupture cause painful vaginal bleeding. Along with placenta previa, the other condition that can cause vaginal bleeding is cervical ectropion, or Vasa Previa can also cause painless vaginal bleeding. So two conditions can cause painless vaginal bleeding, two can cause painful vaginal bleeding. What are the two that can cause painless vaginal bleeding? They are placenta previa and cervical ectropion. They can be differentiated on transvaginal ultrasound. And what are the two conditions that can cause painful vaginal bleeding? They are placental abruption and uterine rupture. And they can be differentiated on the basis of history. So as I have told you before that antepartum hemorrhage after 24 weeks of gestation, so the bleeding after 24 of gestation is known as antepartum hemorrhage, and bleeding before 24 weeks of gestation is miscarriage. So the causes and the diagnosis of antepartum hemorrhage is clear to everyone.
Yes, sir.
Is there any question? Okay. So what is miscarriage? Loss of pregnancy before 24 weeks of gestation. So loss of pregnancy before 24 weeks of gestation is known as miscarriage, and loss of pregnancy after 24 weeks of gestation is known as stillbirth. So miscarriage is if there is spontaneous loss of pregnancy before 24 weeks, and stillbirth is if there is a loss of pregnancy after 24 weeks. What are the types of miscarriages? 5 types that you need to remember are threatened miscarriage, inevitable miscarriage, incomplete miscarriage, complete miscarriage, and missed miscarriage. First, we will discuss threatened, inevitable, and missed miscarriage. These 3 types. Remember that only in inevitable miscarriage, the cervical os is open. So a woman with vaginal bleeding before 24 weeks of gestation with an opened cervical os, then we will say it's inevitable miscarriage. Because the cervical os is open and there is nothing that we can do to prevent this miscarriage. So it is known as inevitable miscarriage. The other 2 types, threatened and missed miscarriage, in both of them, cervical os is closed. So threatened and missed miscarriage, they have a closed cervical os. How you are going to differentiate between threatened and missed miscarriage? In missed miscarriage, as its name indicates, we have missed the miscarriage because as nothing happened. So in missed miscarriage, there will be no fetal heart on ultrasound. And in threatened miscarriage, there will be visible fetal heart rate. Threatened is that there's a danger that a miscarriage can occur. And missed miscarriage is that the miscarriage has already occurred, but we have missed it. So these are the 3 types of miscarriage: threatened, inevitable, and missed miscarriage. In inevitable miscarriage, cervical os is open. So it's straightforward to diagnose. This is the only type of miscarriage in which cervical os is open. While in threatened and missed miscarriage, the cervical os is closed. To differentiate between them is we need to see fetal heart rate on ultrasound. So if there is no fetal heart rate, we'll say it's a miscarriage, and if there is a fetal heart rate, then we'll say it's a threatened miscarriage. Now, a miscarriage can be complete or incomplete. If all the products of contraception are expelled, then we'll say that it's a complete miscarriage. And if not all the products of contraception has been expelled, then we'll say that it's a incomplete miscarriage. So this was all about the types of miscarriages and how to diagnose them. Is it clear, everyone? Or is there any question? So our next topic is chorioamnionitis. So before we start chorioamnionitis, can someone answer my question that vaginal bleeding before 24 weeks of gestation plus a closed cervical os plus visible fetal heart rate? What is the diagnosis?
Threatened abortion, threatened miscarriage.
So threatened.
Yes, threatened miscarriage. That's the right answer. So chorioamnionitis, as its name indicates, it is an infection of the fetal membranes, chorion or amnion. So the only way infection of a chorion or amnion membrane can occur is that if there's a premature rupture of the membranes. What is a premature rupture of the membrane? The rupture of the membrane before its time is known as premature rupture of the membrane. And preterm rupture of the membrane means rupture of the membrane before term, that is before 37 weeks of gestation. So if somebody with a history of preterm premature rupture of membrane or premature rupture of membrane present to you with fever and tachycardia, these two features are most important to say that it's an infection, because fever always indicate infection. Someone with a history of premature rupture of membrane and fever and tachycardia, you will suspect chorioamnionitis. As it is an infection, so the treatment will be IV antibiotics such as ampicillin and gentamicin. What are the other features that can be present because of fever or because of infection? There will be abdominal pain, uterine tenderness, and fetal distress, and a foul smelling amniotic fluid. So these features can also be present. The thing that you need to remember is that the risk factor for chorioamnionitis is premature rupture of the membrane. Sometimes in the exam, because there is a premature rupture of the membrane, so amniotic fluid will be lost through the ruptured membranes. So the female may have oligohydramnios on ultrasound or a small foldate uterus because of loss of amniotic fluid. Oligohydramnios or small foldate uterus will be mentioned in the scenario sometime. And the other clinchers to make a diagnosis of chorioamnionitis is high WBC and CRP. High WBC and CRP, they indicates an acute infection. So all the clinchers such as fever, tachycardia, high WBC and CRP, oligohydramnios and small foldate of uterus, they will point toward chorioamnionitis. Sometimes in the question, they only give a feature of tachycardia with a history of premature rupture of membrane. So maternal tachycardia with a history of premature rupture of membrane, because tachycardia is usually the first thing that occurs in chorioamnionitis. So sometimes only tachycardia will be given and other features will not be given. So your diagnosis will still be chorioamnionitis and the treatment will still be antibiotics such as ampicillin and gentamicin. So small foldate uterus and large foldate uterus, how to date the uterus according to symphysis fundal height. I remember this table that at 12 week of gestation, the fundal height, the fundus of the uterus reaching up to pubic symphysis. At 20th week, it reaches the umbilicus, and between 20 to 36 week, the gestational age is calculated. Sorry, the SFH is calculated by gestational age plus minus 2 centimeter. So at 22 weeks, for example, at 22 weeks, and the SFH should be 24 or 20. So to calculate the SFH or symphysis fundal height between 20 to 36 weeks is that we add or subtract 2 in the gestational age and we'll have our SFH or symphysis fundal height. And after 36 weeks, the SFH should be at or the fundus of the uterus should be at the G5 process of the start. Some causes for large foldate uterus. Polyhydramnias is an important cause for large foldate uterus, and oligohydramnias, they are cause for small foldate uterus. Hydratiform mole can also cause large foldate uterus. So this is also an important cause. Hydratiform mole we'll discuss in the coming slides. Macrosomic fetus, a large size fetus can also cause large foldate uterus, and concealed accidental hemorrhage, twins, tumors or fibroids or ovarian cysts, or fetal malformations such as hydrocephalus, all of them can cause large foldate uterus. The causes that you need to remember is hydratiform mole. And small foldate uterus, they are caused by oligohydramnios, fetal death, and IUGR or intrauterine growth restriction, or small fetuses. Malpresentation or transfer slide can also cause small foldate uterus, and pregnancy during period of amenorrhea can also cause small foldate uterus. So we are done with chorioamnionitis. The short summary of chorioamnionitis: it's an infection of chorion or amnion because it's an infection. So there will be fever and tachycardia, IWBC and CRP, and the treatment will be IV antibiotics. Is it clear, everyone, up to this point, or is there any question? Our next topic is hyperemesis gravidarum. Normally, nausea and vomiting is a normal phenomena in pregnancy, but if it becomes rare, persistent, or uncontrolled, then it is known as hyperemesis gravidarum. As its name indicates, it's hyperemesis, excessive and persistent vomiting, or severe or prolonged nausea and vomiting that occur in a pregnant woman between the weeks 8 to 12 of gestation. It may continue up to 20 weeks or even continue beyond 20 weeks as well. So excessive and severe and prolonged vomiting in pregnancy is known as hyperemesis gravidarum. The management of hyperemesis gravidarum is simple. First of all, because there is excessive vomiting, excessive vomiting will lead to fluid and electrolytes loss. So we fear dehydration. So the initial step will be IV fluids in the management of hyperemesis gravidarum. And because of excessive vomiting, hypoglycemia will occur. And whenever there is low glucose in the body, then the body switches to another fuel, that is, they obtain the energy from ketone bodies, which is formed by the oxidation of fatty acids. So the patient with hyperemesis gravidarum can have ketonuria, and because of excessive fluid loss, she can have tachycardia, weight loss, sunken eyes, decreased skin turgor, prolonged capillary refill time. If these signs and symptoms are present, then it indicates hypovolemic shock. So the initial management will be IV fluids and electrolyte management. And due to excessive vomiting and persistent vomiting and decreased oral intake, what are the other possible complications of hyperemesis gravidarum? Excessive vomiting can cause a tear in the mucosa of the esophagus, which is known as Milry-Weiss tear, which can present with hematemesis. So hematemesis is a complication of hyperemesis gravidarum, and vomiting can also result in an acute thiamine deficiency, and thiamine deficiencies can lead to wernicke's encephalopathy. So these are the two possible complications of hyperemesis gravidarum. And there's one more complication, and that complication also arises due to hypovolemic shock. So which organ is affected when a person develops shock? In shock, which is the organ that is affected first?
Kidneys.
Kidney. So, yes, kidneys. So acute tubular necrosis can also occur as a complication of hyperemesis gravidarum. So remember these three complications: wernicke's encephalopathy, Milry-Weiss tear, and acute kidney injury due to acute tubular necrosis. The management is simple: fluid, antiemetics, steroids, and thiamine. First step is intravenous fluids, and then intravenous antiemetics. Which antiemetics can be used in the pregnancy? The first line antiemetics are zine family, cyclizine and promethazine. And the second line antiemetics are metoclopramide and ondansetron. All of them will be given IV because the person is vomiting, so she cannot take any oral medication. That's why IV antiemetics will be given. The first line antiemetics are cyclizine and promethazine, and the second line antiemetics are IV metoclopramide or ondansetron. So first step is IV fluid. Second step is, in first step, along with IV fluids, we can add potassium supplements to the fluids as well if the patient potassium level is also low, less than 3.5. The second step, antiemetics are given, and if there's no improvement with antiemetics, then the third line drug is IV steroids. And in the fourth step, we add thiamine to prevent wernicke's encephalopathy. The most common cause of Wernicke encephalopathy is chronic alcoholism, but it can be caused by excessive and persistent vomiting due to other reasons as well, such as that occur during hyperemesis in Gravidarum. So, stepwise management of hyperemesis Gravidarum: intravenous fluid, intravenous antiemetics, intravenous steroids. If still no improvement, then parenteral nutrition. And if there is still no improvement, then we need to terminate the pregnancy to save the life of the mother. Hyperemesis gravidarum basically occur due to high beta HCG levels. High beta HCG level can result in hyperemesis gravidarum in some females. So this was all about hyperemesis gravidarum. Is there any question anyone want to ask up to this point?